shown one of the one of his lectures, a world map, and he showed there are 70 students, any corner, nook and corner of the world, his students are there. Though he has said here he produces 70 postgraduates, maybe more actually. So he produced, of course, this is by academically, and then wherever he goes, he has a knack of speaking well, and then getting the points to the core. Professor Ramnath Misra is at present he was a professor and head actually SGPJ. All of us know about that, Lucknow, and now he is at Bhubaneswar, the Kalinga Institute of Medical Sciences. After his graduation 1977 in medicine, 1982 in SCB Medical College, Cuttack, he was trained at ICMR Talent Search Research Officer, Professor Malaviya, Division of Clinical Immunology, AIIMS, New Delhi. I just completed my MD degree from AIIMS in 1982, and then he has come, and we have a good interactions those days. We are disclosing our age, Ramnath Misra. Subsequently, as a recipient of Arthritis Rheumatism Council Fellowship, this is very important in his lifetime. He has a Rheumatism Council Fellowship he moved to UK in 1986 to work with Professor R.N. Maini. You know, he's a founder of the Infliximab, the co-discoverer of anti-TNF therapy at the Kennedy Institute of Rheumatology, London. Then, of course, he joined SGPGA, then now at Kalinga, has so many students at his credit, and he is a recipient of the Samantha Chandrasekhar Award by Odisha Vigyan Academy and the SR Naik Award for Research Excellence from SGPGA, Lucknow. He was the past president of Indian Rheumatology Association. He is a fellow of Royal College of Physicians, London, and the National Academy of Medical Sciences. There is another big list, but I think I'll stop here and request Professor Misra to talk on molecular and biologic targets in the management of autoimmune rheumatic disease, cytokine to secondary messengers. It's a bit going off my head, but I think you may make it more clear for us. Thank you very much.
Thank you, URK and Chandrasekhar for inviting me again and again to this gathering. I'm very privileged for your kind words. We started life together, and sometimes I wonder if I would have followed URK path, maybe it would have been better. My brief is to share with you the targets of the biological agents, the cell-directed therapy, and the second messenger. We can call them as they are signal transduction molecule, hence called second messenger, and we'll call them kinase inhibitors. This cartoon, can I have a pointer? On the top, it shows two panels. The right on the plain side is molecules or the immune response, the innate immune response, and on the left side the B cell ontogeny, which is the adaptive immune response. So these are the two main cells. They are the macrophage and the antigen presenting cells. When something goes inside the body, they are like they wake up and produce IL-12. That is the cytokine which the body triggers as something is wrong. Either it's a microbe or it's a self-antigen. The macrophage and dendritic cells are like guards and they don't know anything. They just fire, liberate some small molecules to tell the body that something is going wrong. And then, in a systematic way, the macrophage and the dendritic cells, they engulf the foreign antigen, sometimes autoantigen, and digest into many small pieces to peptide level and present to the T cell. And the T cell in its turn, there are 4 different types, the Th1, Th2, Th17 and T regulatory cells. They have their own set of cytokine and produces T helper cell, which engages the B cell to produce antibodies. So, to eliminate foreign microbes or tumor cells. Something goes wrong in 5 to 10% of individuals that the antigen recognition system, it gets garbage. It identifies cell structure as foreign and tries to eliminate it. How that occurs, we may need 2 or 3 set of series of lectures. And then these small molecules, they are called cytokines. They are amplifier proteins. They amplify the entire system. One cell cannot exclude an infection. You need to engage many cells, so you need these small molecules. And these molecules, cytokines, they have their own receptors. They engage the receptor, and once they engage the receptor, inside the cell, there are signal transduction protein. One protein gets attached to the other, then a protein gets phosphorylated. It goes into the nucleus to produce a protein that is desirable. These intracellular mechanisms, mind you, they are very quick. And they're so quick, the system is, it's better than any man-made system, like they have now drones, missiles. This is the target, the design. You give an antibody of 5 amino acid protein, it will produce an antibody exactly fitting to that in 3 days' time. You give COVID virus, body doesn't waste time. It produces an antibody in 5 days' time. We cannot produce that in artificial, and with each successive division of the cell, the antibody is better, it's better. So, it's a very unique system. And then how cell talk to each cell, that is also a very important intricate mechanism. The macrophage talks to the T cell, it presents the antigen, and it presents a second signal. Only then the T cell produces IL-2, the T cell becomes active. So you remember macrophage, dendritic cell, they produce IL-12, interferon gamma, and the T cell cytokine important is IL-2, interferon gamma. This is the cause of the regulation and dysregulation that lies behind our disease. I worked with the gentleman on the right under him, Sir Professor Manning. The other gentleman is Mark Feldman. And I was there between 86 to 89 in UK. When these experiments started for rheumatoid arthritis. Before that, rheumatoid arthritis was a jungle, no one knew. Much like SLE now, it's a jungle. What's going on in this mad world? So, They did very simple experiment. On the advice of an American, many people don't know, his name was Dweffler. He came from Texas and he suggested, like we do in microbiology, we culture the bug, treat it with antibiotic and then find which bug is there and which antibiotic works. So Dweffler was a smart guy from Texas. He said that there are millions of things in that rheumatoid synovial fluid. Why don't you invest there? So they took out what is called as cartilage explant. If you take out the cell and grow outside, the cell loses its nativeness. You take out a tumor cell and try to grow, after 3 divisions, the invasive property of the tumor cell is gone. So they called it, the first time, a cartilage explant. Small bits of cartilage they put in petri dishes. And there was an Irish lady and a Scottish lady, Fionnuala Brennan. They tried hours and hours, and many asked me which one you want to do, rheumatoid or SLE. I thought SLE is more exciting. Rheumatoid is very boring. So I followed the SLE pathway, became infamous. Now, they wanted to see what all things are there. These small molecule IL-1, IL-6, TNF, GM-CSF. Interestingly, IL-2 is not there. The IL-2 is the growth factor for T cell, and gamma interferon was there. So they had anti-TNF antibody, anti-IL-1 antibody, anti-IL-6 antibody, anti-TNF. Welcome, Vinita. As always, you are late. So, the next thing was to try out each and see which is reducing the cytokine. When they did that, if they give anti-IL-1, IL-1, the cells stop producing it. If they gave anti-IL-6, they stop producing anti-IL-6. But when they tried anti-TNF, all the cytokines were downplayed. This was all in the lab. So they thought that probably TNF has a hierarchical place, like Chandrasekhar has here. He is the top. Nothing can move without him. So TNF probably do this. The same thing was happening 5 miles down the road in a place called St. Thomas Hospital, where Gabriel Penai, they saw, no, it's not TNF. I don't know what it was. It is the anti-IL-1. He is the discoverer of the anti-IL-1 receptor therapy. So, then both the team gave to mice. The mice that was given was collagen-induced arthritis. Anti-TNF mice did work well. Anti-IL-1 also worked well. At this point of time, historically, Centocor was the company and they have tons of anti-TNF in their freezer. And the company's share was plummeting down because anti-TNF maximally is producing septic shock. So when LPS was given to mice and anti-TNF was given, it didn't work. So it didn't clear the human use, and Centocor had tons of anti-TNF in their freezer, and the price came down to 17p from 47p, that the UK pin, and that's a huge amount. So then Manny, Fairman and the company boss, they said, why don't we try rheumatoid arthritis? Ethical clearance is a big issue in UK hospital. You cannot give anything. So these days ethical committee, I don't know how many people you've attended, we discuss over paper. 10 patients were brought to the ethical committee members on wheelchair and sought the permission, and who is the ethical committee constitute? It doesn't constitute a doctor. It constitutes the parish chief, the church chief, a general public who has got no knowledge of disease. They will decide whether the drug is to be given. Very peculiar. We're so conservative with the society, you cannot believe. Sometimes we think we are more advanced than them. But for human protection, UK is the best place. There is no better place, UK or Sweden. You cannot give anything to anyone unless it is very safe. So they give permission because those patients were on wheelchairs. So the first human trial was done in 10 patients with rheumatoid arthritis. They were wheelchair bound. I mean, they couldn't have walked or run for the ethics committee. The ethics committee was reconvened, the same members reconvened to, here we don't meet again. The ethics committee is not asked again to meet. They were reconvened after a first dose of infusion, which was given at a little higher dose, 10 milligram per kilogram body weight, because the dose in mice and in mouse equation, am I taking long time? I can skip the other slide. And the first expression, the patient, all patient said, I have never felt like this any time in my treatment with tiny. I mean, we used to give sulfasalazine, and sulfasalazine was not given gold or penicillamine, and plenty of anti-inflammatory drugs and steroid. So they said that they are off steroid after the first injection, and they felt nothing like this. So then came the first randomized controlled trial, because that is evidence number one, and that brought in an era in 1990 of era of translation medicine, or some say from bench to bedside era. There was no such term coined before that, and huge advances in the technology. The Americans can't fall behind the Europe. So they produced etanercept, and both etanercept and infliximab got FDA approval with very short time, with one publication of that 3 milligram dose, 3 to 5 milligram dose range, Centocor produced infliximab. But soon it was realized that the war is not over. You see any trial with any biologics, there is a rule 40, 60, 80. ACR 70, 80%, ACR 20, 70% improve, ACR 50, 60%. That is true of infliximab also. Means the drug which was supposed to act when methotrexate or aldemard failed, it did not cause 40% ACR 70 response. ACR 70 is a very robust response. So we now know there are many players, and many scientists can thrive, many other industries can thrive. We have over the years seen the anti-TNF, that is the first one. This is a monoclonal antibody to TNF. TNF is a small molecule and it acts by two receptors, TNF receptor 1 and TNF receptor 2. TNF receptor 1 is cause of all inflammation. Whereas, I don't know why, God has given a second receptor, TNF receptor, and that is a good receptor. It helps regulating autoantibodies. It helps regulating the B cell. And this anti-TNF, it acts against both. And many patients who receive these antibodies, they develop SLE-like manifestation. It creates anti-nuclear antibody. And sometimes it can cause a demyelinating disease. So anti-TNF antibody is contraindicated those who had any history of demyelinating disease. Or even if you have a Graves' disease, it's better not to give because it knocks out these TNF receptor 2. And this is such a nice receptor. It checks all the malignant cells. And if you kill those, you have a chance or a theoretical chance of malignancy. So any patient with a history of CA breast, don't give anti-TNF. The soluble receptor, this is the soluble receptor, it mops up floating TNF. It's a milder side effect in that sense because it doesn't take care of the cell-bound receptor, monoclonal anti-TNF antibody, like monoclonal anti-TNF antibody. The anti-IL-1 in therapeutic trial had a modest efficacy as compared to anti-TNF. I don't know why. They had similar result at mice level. 5,000 gene is the difference. Mice has 25,000 gene and human has 30,000 genes. 5,000 gene and anti-IL-1 has a moderate response. Fortunately, there are other inflammatory conditions where the inflammasome gets activated, such as the systemic onset GIA, the adult onset Still's disease, and gout. These are, it works good there. It down-regulates the inflammation there. IL-6 inhibition goes entirely to credit of Japanese. So much so that the IL-6 receptor antibody is a very potent, and in some trial it has worked better than abatacept, better than adalimumab. Adalimumab, all of you know, is the highest selling biological in the world now. It's adalimumab. Of course, we get it very cheap. We play around a bit with it. I don't know about orthopedic surgeon, but we play around a bit with it. Indians have very different strategy, intelligence to use the drugs, to de-escalate the drug that no country can surpass. When to use, when to de-escalate, and how to adjust it with the purse the patient carry. No one, it was used extensively anti-TNF in the army. Chaturvedi had used it a lot. Do you know how he has used it? The money comes in a lot. It doesn't come every year budget, the money comes. So by October all the biologicals will run out. Patient will be off drug between October till the budget is approved and the drug comes in May. When the rain comes in, the patient gets the biologic. That's what it was, he was saying. I mean, scientists would be shocked, some would be having heart attack that Indians can do this. Of course, now the Chinese they have devised some trial, very clever, like the Indian pocket. If it was for a male, there is money. If it was for a female, there is enough money so that the female can prepare the food. Once you start preparing the food, the biological is switched off. So this is such a clever way of prescribing that sometimes it is ridiculous to talk about science here. Then came, this was 10 years down the line when I told you that anti-TNF doesn't work in all cases. And therefore, IL-6 receptor, it works, but still some patient escape if we take rheumatoid arthritis as it. But there are other diseases where IL-17 and IL-23, IL-17 is plentiful in the gut, bronchial mucosa and skin. It is a very protective cytokine. So there is a chain which is shared between IL-17 and IL-23, the anti-P40 chain, and we have secukinumab. It's very good for axpond and psoriasis, and I think all works good anti-IL-17 for psoriasis as well as psoriatic arthritis. All psoriasis, full body psoriasis will get cleared with IL-17 or with ustekinumab. Then came the cell-targeted therapy. This is loved by Indians. Indians ignore ACR guideline, European guideline, so that Smolin redesigned the guideline in 2019, primarily targeting the Indian. Why? The first drug of methotrexate failure was promoted to be used by anti-TNF or a JAK inhibitor, as URK said. Then if that fails after 6 months, rituximab was added on. There is place for non-TNF inhibitor like abatacept but thank God our pharma industry biosimilar have produced reasonable cost B-cell target, the anti-CD20 target. CD20 is a nice molecule in the sense that it is there in the B-cell at the plasma cell level, nor at the very early stage. It is there when what is responsible for the disease. And it doesn't take away the memory cells, so if you have been tetanus vaccine given, that antibody stays, or any previous infection. Abatacept or a co-stimulatory blockade employs CTLA-4, which is tagged with IgG. All these small molecules, the 351 amino acid, they have to be tagged with a larger molecule, either that. So I told you about the second signal. This is the first signal, and the second signal on the T cell CD28, it works with CD8, it gets attached only then the signal is transduced. But CD28 with CD7 and CD80 and 86 is a negative signal. This CTLA-4, it attaches with CD80, 86 and cause downregulation of further signaling. And abatacept is actually a very good molecule in the sense that some disease where all the biologics fail, you can think of. I recently reviewed a case report of immune pulmonary disease, ILD, due to called immune-mediated ILD, where every drug has failed, and they give in abatacept, the Japanese, and 6 years down the lane, the patient is doing fine. I approved for publication, but my second reviewer, he rejected it, and the editor-in-chief rejected it. I don't know why. I thought I was very excited. He said there are 3 case reports before. Maybe I am not studied. So we have B-cell, rituximab, anti-BAF is a B-cell growth factor. We have belimumab for SLE. And T-cell, we have abatacept, which have got approved license for RA and polyarticular GIA. Then comes to the second messenger. Second messenger employs signal amplification through JAK-STAT pathway, and there are 4 JAK. JAK1, JAK2, JAK3, and there is a TYK2. And they help in amplifying transcription of various cytokines. So you give a JAK1 and a JAK2 inhibitor, you are blocking all the cytokines, one at a go. And we have TOFA, which is playing nicely with the orthopedic surgeon. Rheumatoid arthritis, psoriatic arthritis, ulcerative colitis. I have seen some prescription on osteoarthritis by the orthopedic surgeon, where science stops, practicality starts. JAK1, JAK2 baricitinib, rheumatoid arthritis, and JAK1 selective upadacitinib has been approved by both America, European RA psoriatic arthritis, filgotinib by the Japanese. So we have an array of products. The much talked about is the safety profile of kinase inhibition. Kinase are very important molecule for myelopoiesis. They start producing the erythroid, the myeloid cells, development. A key concern is now of thrombosis. A key concern is thrombosis, and the reason is ACR has withdrawn from filgotinib is because the clearance from the pulmonary thromboembolism has been reported in 2 cases. ACR have not given the clearance, but because of the war, EMA approved it. I don't know. This may be war politics. So JAK inhibition in RA actually downplays all these cytokines. But because they are small molecule, the moment you withdraw it, the cytokines are back. So you wouldn't expect something what a B-cell depleting therapy does, 6 months, honeymoon, then you give another, you don't give another. And there are some Indian rheumatologists who claim victory after a single shot of rituximab.